Hi everyone, I'm back. Thanks for watching my videos. Still on sickle cell disease. If you have not watched sickle cell disease parts 1 and 2, I will advise you that you kindly do that so that you can enjoy this very presentation, which is part 3. Part 3 will be totally on treatment. Part 1 and 2, we have covered the inheritance, pathogenesis, symptoms, common crises, and complications. So now it is all about treatment. Let's go. Okay. Again, you can check videos on pathogenesis, inheritance, symptoms, and common crises with complications. That said, anyone diagnosed with sickle cell disease must please have a general practitioner or family physician to be following up, and referral to experts in sickle cell disease will be a golden step to take. Medications for prevention of pain are Hydroxyurea and L-glutamine. Now we can have cure with hematopoietic stem cell transplantation or gene therapy. Some will be placed on penicillin prophylaxis if they are less than 5 years and for the purpose of covering those pneumococcal bacteria, particularly for asplenia or those with splenic infarction. Some parents will even choose to continue the penicillin prophylaxis, while some will opt out after 5 years. Macrolides could be used, that is erythromycin or azithromycin or zithromycin, if the child is allergic to penicillin. It is nice to identify and take child to clinic if fever is greater than 38 degrees Celsius. In other words, we are going to encourage the patient and the family to keep thermometer at home and measure the temperature. And once you discover that it's 38 and above, just contact your doctor. Vaccines are necessary. All vaccines should be up to date. In addition to regular vaccines, both pneumococcal conjugate vaccine and 23-valent pneumococcal polysaccharide vaccine should be taken. The pneumococcal conjugate vaccine, that is the 13-valent pneumococcal conjugate vaccine, will be taken as 4 doses from ages of 2, 4, 6, and 12 to 15 months. While the 23-valent pneumococcal polysaccharide vaccine will be taken as 2 doses at age 2 years old and at least 8 weeks after the last PCV13. And the second dose of the 23-valent pneumococcal polysaccharide vaccine should be 5 years after the first dose of 23-valent pneumococcal polysaccharide vaccine, and at least 3 years if you're going to give it faster. So at least 3 to 5 years must exist between dose 1 and dose 2 of HbSV23. Annual flu shot must also be taken. You can check my video on flu shots. I think I have 2 or 3 videos on flu shot alone. Asplenia or those with therapeutic splenectomy must have 2 doses of meningococcal conjugate vaccine MCV4 at 2 months apart for all the children with sickle cell disease between ages 2 to 10. But anyone greater than 10 years old should receive Men B. Let me repeat. For those who have therapeutic splenectomy or splenic infarction and they become asplenia, 2 doses of meningococcal conjugate vaccines will be necessary. For those who are between the ages of 2 to 10, that is 2 to 10 years, okay, should have MCV4, and it should be 2 months apart. But to those kids greater than 10 years old, they should receive MenB. Leg ulcers. You should check the shoes and make sure that they are fitting well. You can have Doppler for deep vein thrombosis and D-dimer assay. You may choose antibiotics and debride very well, and of course transfusion may be chosen depending on your clinical assessment and conclusions. With or without grafting, you may refer to plastic surgeons as the case may be. You have to rule out pulmonary embolism if DVT is established. And of course, you can check my video on wound care for proper management of the ulcers. It will not be good if I don't mention variant sickle cell syndrome. And variant sickle cell syndrome will encompass hemoglobin SC, hemoglobin SD, hemoglobin SE, hemoglobin SB plus. That is, SB plus means sickle beta thalassemia with some level of hemoglobin A, that is adult hemoglobin, or HbSB0 when there is no adult hemoglobin A. In these cases, they will have less infection, but I want you to pause and listen to what I'm about to say below. SC will not frequently have crisis, but one episode may lead to death. And you could see that I've highlighted that. SC, hemoglobin SC, now affected people may not frequently have crisis, but one single crisis may lead to death. Hemoglobin SB0 is just like HbSS. Hemoglobin SB0 is just like hemoglobin SS because there is 0 adult hemoglobin. Hemoglobin SB plus will have variable adult hemoglobin. Hence, they have less severity of symptoms. Pulmonary hypertension. You can rule out pulmonary hypertension with transthoracic echocardiography, TTE. And you can also do your complete blood count, LDH, electrolytes, glucose, pH, and backup. Edema of the lower limb could be treated with elevation, rest in bed, compression using bolts, and Coban compression. And of course, if it is massive, you can use diuretics. If you are encountering poor wound healing, you can check my video on wound treatment again. But in case of sickle cell disease patient, you can use Hydroxyurea. You may choose to transfuse depending on your clinical assessment. Let there be proper diet, please. You can involve dietitian if you think the affected family and patient may not understand or may not cooperate. Proper debridement is key to good wound healing. You can use 2% sodium nitrite cream and Timolol topically. Folic acid is prescribed 1 mg per hour once daily, but that is not necessary in advanced nations where food items are already fortified with enough folic acid. In other words, folic acid is mandatory in poorer environments where the food intake may not have adequate folic acid. No iron, please, but we have to rule out iron deficiency, because the fact that they have sickle cell disease doesn't mean they cannot have iron deficiency anemia. The reason why we don't give iron is the sickle shape of the red blood cell will predispose to blockage, and with apausia, they are prone to fragmentation. And when that occurs, iron is also released in the circulatory system. So it is presumed that sickle cell disease patients as well as thalassemia patients will always have high level of iron in the circulatory system. So we don't want to complicate that, giving them exogenous iron when already they are producing excessive iron. And if you have listened to my previous presentations on sickle cell disease, I have explained in detail how excessive iron could lead to infection, infection leading to fever, infection and fever leading to hemolysis, and more iron in the circulatory system. So it's a kind of vicious cycle. You may give B complex and vitamin A, D, E, K. Hypertension. You have to treat hypertension immediately. And why that? Because there's possibility of increased stroke or silent cerebral infarction. You can have transcranial Doppler with adequate transfusion in hemoglobin SS and hemoglobin SB0, because they're going to have similar presentations all the time. You have to refer to ophthalmologists at age 10 to find out if there is retinopathy and detect the same and embark on treatment promptly. In case of asthma or renal failure, sickle cell disease patients will have increased chances of having asthma, and is worse in children with family history of asthma. So we have to take proper history and do a physical examination, looking for telltale signs of asthmatic attack. And of course, obstructive sleep apnea that is possible to increase in sickle cell disease patients. Priapism is very common, and you drain appropriately. As a matter of fact, I'm going to go to more details about that in a bit. And if it is renal failure, you have renal function test from age of 3 years. Like when I was talking about leg ulcers, and in case there is poor wound healing, you need good diet. The good diet should include calcium and zinc. There should be growth monitoring, because the children affected will probably have delayed growth and of course delayed maturation. Avascular necrosis of the hip is common with pain, but no matter how compassionate you are, please no meperidine or ketorolac here. Acute coronary syndrome could be treated with incentive spirometry, and of course generous hydration, and adjusts with or without transfusion as you deem it fair. There should be prophylaxis for venous thromboembolism, and you have to do your D-dimer and Doppler, and of course so many other tests to establish that. So once that is established, you have your heparin or low molecular weight heparin, for example, enoxaparin, fondaparinux at 2.5 milligrams of cubed, and unfractionated heparin at 5,000 international units of cubed twice daily. In case of sequestration crisis, if you've listened to my previous presentation on crisis, I've explained in details how sequestration crisis could lead to immediate death, just like acute coronary syndrome. In case of sequestration crisis, you can have blood transfusion. You have IV fluid, normal saline, and of course surgery immediately to have the spleen removed, splenectomy. And I can remember I've earlier stated that even if you want peace of mind for yourself and for the patient, you can suggest prophylactic splenectomy so as to save the family. And I gave example of the family that I knew of who had two kids with sickle cell anemia, and they were about taking a long trip across the Atlantic, and they were advised to have therapeutic splenectomy or prophylactic splenectomy. They had it done and they had peace of mind. No granulocyte colony stimulating factor, for example, filgrastim, no. In case of Priapism, you drain with needle aspiration, then use phenylephrine injection, copious hydration, and of course, blood transfusion if concomitantly with decompensating anemia. You can have analgesics. Here, you will not use meperidine and ketorolac, but you can use diclofenac, naproxen, opioid, but be careful about opioid addiction, and of course, PCA. Survival depends on sensitivity of the parents, severity of the disease, sophistication of the treating center, support given by everyone, and of course, the site. Someone may ask, how do you mean? Yeah. Let's give two scenarios. A child with educated parents and who are conversant with signs and symptoms and crisis of sickle cell disease and what to do immediately, and the other parents who perhaps have not even made the diagnosis because they've not visited any doctor for the same purpose. Which one do you think will survive? The answer is glaring. And that is what I meant by sensitivity of the parents. Severity of the disease, like some with hemoglobin SC that may not have crisis, but only have crisis once, compared to hemoglobin SS and hemoglobin SB0. If you compare that to hemoglobin SB+, they have less severity of troubles. So, isn't that clear enough? Sophistication of the treating center. Like I have just mentioned that now there's possibility of cure with hematopoietic stem cell transplantation. That is not done in many centers around the world. Only few places could do that, okay? And even some clinics, some medical centers in some parts of the world might not even be able to meet up with many things that these affected individuals will need. So imagine visiting a clinic or any hospital and you have everything in place, including strong opioids that will relieve the pain quickly and transfusion within few minutes, and all vaccines are taken because they are available. Isn't that clear that affected individuals in such regions will live longer? Support given by everyone. Of course, if you don't have support, particularly sickle cell disease patient, nobody to take them to the hospital, nobody to provide for their good diet that will help wound healing and maintain life, of course, you will understand that the difficulty is high there. The site, that is the environment. 4 nations rich nations. I need not wasting your time on that. With that, I've come to the end of the treatment. The next presentation will be on prevention. Thanks for listening. Kindly subscribe to my channel so that once these presentations are published, you can have a copy immediately. I appreciate it.